Hey y'all, I'm going to make a quick video on some respiratory stuff for you guys, respiratory emergencies. I'm not going to do a video on how to treat that yet. I just want to talk about some of the respiratory emergencies that you will encounter. So first, to know what's abnormal, of course, you've got to know what's normal. And that's why I encourage you to listen on every patient, whether they are sick or not, because if you don't know what normal lungs sound like, how are you going to know what abnormal lungs sound like? So let's talk first about how the whole respirations and ventilation and oxygenation stuff happens. So we know that ventilation is the actual act of breathing. Respiration is that exchange of gases and from oxygen into CO2. So, what happens is the air exchange where it becomes respiration is at the site of the alveoli, which is those little great bundles I talked about. Or I think it says in your book you want to think of it like a straw with balloons on the end of it. So, in proper air exchange, you breathe in, and so when you breathe in or inhalation, what's happening is your diaphragm goes down, your ribs and chest wall come up and out as that diaphragm pushes down, and then the exchange occurs at the site of the alveoli. And then it changes from oxygen to CO2 and then flows back around through your heart. Now, if there's a problem with the alveoli, that's where the issue comes in. So alveoli are little small sacs. They work the best when they are constantly semi-inflated. So, and the way that they can do that easily is stuff called surfactant. If that surfactant wipes off of them, then that cell exchange doesn't happen as well as it needs to, and then you get that buildup of CO2 retention. And then you get what's hypoxia, you get a hypoxic drive. We'll talk a little bit about that in a second. So then when we breathe out and we're exhaling, that's when our diaphragm moves up and our chest walls move down, they move back and down. So if there's a problem with that surfactant, like I talked about, somebody with smoking, somebody who, a really good instance that you don't really think about is somebody who's drowned, especially with that salt water. It removes that surfactant from the alveoli, so there's not a very good gas exchange. And over time, there, you want to think of it like a highway. So, say from the pulmonary vessels, the pulmonary arteries, the pulmonary capillaries, think of it like a highway. It's a four-lane highway. The red blood cells, which are the oxygen carrying blood cells we know, can travel down that four-way highway of a healthy person and not have an issue. But that surfactant starts washing away, so then that area for the red blood cells to get through becomes narrow and narrower. So just like a four-lane highway, think of the same amount of cars that were going down that four-lane highway, all of a sudden now are only going down a two-way highway or a one-way highway. There's going to be a buildup, and those red blood cells get more sluggish. They actually get wider in appearance as that happens, and they can't travel through as fast, so then you have less oxygenation and more hypoxia going on. So over time, somebody who say has COPD, heavy smoker, has right-sided heart failure. So how you start to get right-sided heart failure? Let's just break that down. It's called cor pulmonale, and that's where over time, you know that highway goes from four lanes to two lanes, and then your body pretty much there's not enough exchange to go to the left side of your heart, so it starts to go to the right side. It just basically shunts off and just goes to the right side, which is the unoxygenated side, right? So then it's less oxygenated, and you're just moving around less oxygenated blood versus if you had good air exchange. So then they get what's called a hypoxic drive. And so when your body stimulates you to breathe, it comes from, it starts in the medulla and the pons in your brain, and then it goes down your spinal cord, and then it triggers the phrenic nerve um, and the nerves in your intercostal muscles to work, right? So if somebody has a brain injury and that part of their brain is injured, it won't tell them how to properly breathe. Or if there's some kind of issue where there's that buildup, it doesn't breathe as normal. So what a hypoxic drive is basically is that your body tells your brain tells your body when to breathe. So when your body senses that it doesn't have enough oxygen, it will say time to time to inhale, time to get some of that oxygen, time to exhale, time to release some of that CO2. Well, somebody with a hypoxic drive, if they're used to thriving on 94% oxygen, 93% oxygen, because that's how they've lived for a long time, their brain remembers that. It says, okay, we're surviving just fine on that. Well, then you give that patient some supplemental oxygen, and it's 15 liters, and you're going on, I don't know, an hour long trip, which is not necessarily true for a lot of the places, but it is with us. So your body senses all of that extra oxygen. So your brain is not saying, hey, it's time to breathe again, because it feels like it's got enough oxygen. So it's not triggering that response. So their respirations can drop and sometimes even give out. But an important thing to remember is you never, ever, ever withhold oxygen from somebody who needs it. You are most likely not going to be able to throw off that hypoxic drive in the short time that you get them. That's more of a long term stay in the hospital or maybe an extended care facility. So don't ever withhold the oxygen. Okay, so that's a quick down and dirty about the respirations. And so let's talk about some respiratory emergencies. We're going to do upper and lower airway. Remember, the pharynx is the divider between upper and lower. So everything from the bottom of the pharynx up is upper, everything from the bottom of the pharynx down is lower. So some common ones that we see are asthma, anaphylaxis, bronchitis, congestive heart failure, emphysema, epiglottitis, things like that. So let's talk first about how do you know somebody's having difficulty breathing? Like, of course, we all expect them to be gasping and look like they're struggling, and that is going to happen. But some people, it may be more subtle than that. You'll see the cyanosis around the lips, which means what? That they're not getting good oxygenation. So those red blood cells are not carrying the oxygen like they should be. Also, what we call retractions. That's where your neck, you can see them breathe in and out. You can see their neck muscles or their belly muscles, their intercostal muscles working overtime. Also, a late sign is tracheal pulling. That's why when we do our assessment, we look for midline trachea. If it's pulling to one side, that means the side that it's pulling to is getting good oxygen. That other side is not. But if you encounter that, you are late. You better oxygenate as quick as you can. And they probably are going to need decompression, or they've got blood, or they've got something that's blocking the air from getting through that lung well. So, okay, so asthma. Is asthma an upper or lower airway problem? It's bronchospasm, so you got to think of where the bronchioles are. and that is lower, right? So it's a lower airway problem. And so, what do you expect to hear? You expect to hear wheezing. Sometimes it may be really fine wheezing and you don't really know, but you can see that that person's struggling. And you use my favorite tool of all, which is that CO2 monitoring. And if you see what looks like a shark fin, then that's showing that there is constriction somewhere in the lungs. They are not being able to take a full breath in and a full breath out. So, what happens with the breathing ratio is usually you breathe. The breathing ratio is 1 to 2 inspiration versus expiration, just as a normal. So, somebody um, like my partner Jordan, who's over there minding his own business, doing some paperwork over there, he will breathe in 1 second and breathe out 2 seconds. So that's normal. You get somebody like me who is running around like crazy and who has been a smoker for years, and it may be prolonged for me, or somebody who's got asthma. So emphysema and asthma are a lot alike in that it's a lower airway constriction problem. So you'll see that their expiration time is a lot longer. Sometimes it'll be 1 to 3, 4, maybe 5. Um, so they need that. They need some sort of medicine to bronchodilate them to get that air exchange in. Let's talk about anaphylaxis. So some signs and symptoms of that, which I hope that we've all beat through you, but we'll get a little more into immunological emergencies later. But they'll have flushed skin, generalized edema, decreased blood pressure, which is hypotension, and they'll have laryngeal edema and dyspnea. So is that an upper or a lower? Because it's the larynx. It is right at the beginning of the lower. But it's right there where it starts to go down into your lungs. So if you think about it, it's right here, and then it branches off into your lungs. So if this is swollen, you're not getting any air in this way. Or I mean, you can get it in this way, but then it's like blocking from here down getting good air exchange. So you'll hear wheezing and stridor. Stridor is that real high pitched wheeze that we talked about, almost like a seal bark. If you hear stridor, that patient is in bad respiratory distress, and you can find that with epiglottitis as well as anaphylaxis, because that's basically, think of like squeezing someone's neck right here. You're not getting good air exchange, and they'll be like, ee. I mean, that's just the best way to describe it. So with that, you want to get that epi in there to vasodilate and help. Vasoconstrict and help get that oxygen moving back in that area and help the release of the pressure. So bronchitis. So everyone has had bronchitis. Well, probably. Or knows somebody's had bronchitis. Ain't nobody got time for that, that whole thing. So that usually presents with a chronic cough, wheezing, cyanosis, tachypnea. Tachypnea is what? Fast breathing. Somebody who, so instead of their respiration ratio being 1 to 2, it might be 1 to 1. They're fast breathing because they just can't catch their breath. Congestive heart failure. So what happens with that, basically, and we'll of course get into most of these a little later, because they have a lot to do with comorbidities. They have to do with the heart, because remember, every system affects another system. Your body is constantly trying to get to that state of homeostasis, which is where everything is even. So when you give from one, you take from another, and vice versa. So with congestive heart failure, you a lot of times have fluid blocking that air exchange. So you'll hear pulmonary edema and what we call crackles. It'll be almost like someone's breathing through a straw. And the best way to listen to that is anteriorly. And just always remember crackles in the backles. If you can hear that in the back, it's probably because they've got fluid in their lungs, whether it be chronic or acute. We went over that before. Something that's chronic is long term, something acute is on now. And you can have an acute problem with a chronic problem in one, but you need to identify. So the acute version of the fluid in the lungs would be pneumonia. There's usually some kind of pus or fluid or some kind of infection in the lungs. And then the chronic version of that is CHF, or chronic congestive heart failure. We also have the common cold, and that's basically, we call it pleuritic pain. So there's that pleural space in your chest that is irritated. So it is causing your body and hitting that vagus nerve, and that vagus nerve causes your body to cough, and it's basically spasming. Let's see, what else? We talked about emphysema. Something that you will see in an emphysema patient is a barrel chest, which is rounded, and that means that it's a chronic problem. Also, something that I learned really recently is that people with chronic breathing problems have clubbed fingers. So if you look at them, they're short, stubby, more rounded, and their nail beds kind of fold in. That was something I learned recently, and just thought it'd be good to know. But someone with emphysema usually has pursed lips, and they're struggling, and they've got thick phlegm in their throat. Let's see, last one. Oh, epiglottitis. If you have a kid in epiglottitis, it is a true emergency, and you need to be very careful with that. So with epiglottitis, itis means infection in the epiglottis. Obviously, the name says it all. But they'll have stridor, which is that high-pitched wheezing. They'll have dyspnea. They'll have drooling. And the reason that they're drooling so much is because they can't swallow that because it's so infected and swollen, right? So then they'll have a severe sore throat, and you'll see them tripoded over. And I hope everyone knows what we mean when we say tripoded. They'll be bent over, hands on their legs, just really struggling, or maybe hands behind their back, just struggling, trying to get to breathe. Or they'll be in the sniffing position, and that's the body's natural mechanism to try to line up that airway so it's as straight as it can, so you can get as much air exchange as you can. Some things that maybe are not health related is pneumothorax, and that's with sudden chest pain, dyspnea, and you can either do that from a hard hit. Some people who are just really tall and they don't have that elasticity in their chest to inhale and exhale well, and it will pop a lung, and then so you have to really listen to lung sounds on both sides to make sure that you hear both of them, especially if they're in a trauma patient. That's why we hear it, because if they've got a pneumo, that means that the air is trapped on the outside of the lung versus inside where it's making that air exchange. So all of that air is building up. And if you think about a balloon inside another balloon. So you've got your lungs that expand, and then they're inside your chest wall that also expands and contracts as you need. So if that gets damaged and it takes a hard hit and it pops that lung, you've got air slowly filling out inside of your chest wall, and then that puts more and more pressure on your lung, so that way it can't expand and open up as it needs to. So then they can't breathe. You'll see tracheal tugging. You'll see distended neck veins, unilateral breath sounds, which is on one side, and probably low oxygenation. The same with pulmonary embolism. When you block that, if you get a PE, it basically throws a clot that will block the pulmonary arteries and pulmonary veins from getting that air exchange. So it's got to find. So the heart is really cool, and the lungs are really, the circulatory system in general is really cool. That if it comes across a block, and there's a block in the road with a blood clot or whatever, it will make another route. It will find a way to get to where it's going and get through the heart any way that it can. But just like if you take a detour on the highway, it doesn't always mean it's faster. In fact, most of the time it's not faster because it's got to go around things, up, under things. So that happens with a pulmonary embolism, but it takes longer to get there, so it gets less oxygenation. It takes longer to oxygenate. So you will notice with a PE, a lot of times they present with low oxygen saturations. It's usually like in the 80s, and they will not be able to sit back because when they sit back, they cannot breathe. The lung can't expand very well, so they start getting super panicky and they have to sit upright. The same happens when there's fluid in there. If your lungs can't expand and contract and exchange oxygen like they want to, it kind of sends your body into that flight mode. I'm sorry, into that flight mode, and then you get panicky, real worked up, and then of course we know that that doesn't help their breathing at all. Respiratory syncytial virus, that's a special place in me. You guys all know about the story with my son. That's basically a cold for you and I, but there is too much phlegm to get good oxygenation, and it's blocking that airway. But they're so young, because it usually happens with babies, that they're not strong enough to hock a loogie or spit it out like you and I can. So that is kind of just a quick down and dirty of some of the respiratory stuff and what to look for. I have been at work for a very, very long time because I got called in for an emergency. So I'm trying to do this all like in between calls. So I'm sorry if it's panicky. Call me if you need to. I will be off of work tomorrow. Then I will be back at work for the next foreseeable future. So, I mean, chances are great. Even if you call me at 1 in the morning, I will still probably be able to answer the phone. If you have any questions, call me. Like I said, thank you guys. I miss you guys. Looking forward to the next class. I appreciate your patience.